and Family Welfare NCD Division, Government of India. I welcome you all to this webinar series hosted by the NP NCD Division of the Ministry of Health and Family Welfare. This webinar series is being conducted every 2 to 3 weeks on a special theme which is related to non-communicable diseases. And already many of the non-communicable diseases like obesity, COPD, diabetes, stroke, kidney diseases. So many experts have deliberated on such topics. The whole motive of conducting these webinars is to educate, to reinforce the commitment of the NCD division to empower our basic health workers who are working across the country with the simple expertise and the knowledge which our experts will share over this platform. So hypertension is, as we all know, is something which may come with some symptoms or which may not come with symptoms. It may be a totally asymptomatic disease, or it may present to you with some overt complication, maybe some stroke or some heart failure or something like this. So to address this very important problem, the government of India, it pledged that around 75 million people in the country will be treated by the end of 2025 for hypertension. And this could only be achieved with the help of a collective effort by the people, by the healthcare workers. The primary thing which will be to detect any asymptomatic patient who has high blood pressure. But this is not very simple. Sometimes we may do some error in taking the blood pressure. Sometimes we may overdiagnose the hypertension. And even if we diagnose the hypertension, people may ignore that they have hypertension because they may not have any symptoms of hypertension. So to address all these issues related to hypertension, and as a part of our commitment to observe important health issues in the form of observing days like Hypertension Day, which was on 17th of May and was celebrated worldwide to focus on the etiology, on the complications of this disease. Today, we have with us a very, very senior, a very educated, a very learned personality. He is Dr. A. Muruganathan, sir. Sir is director of the API Physician Research Foundation, which is a national body which, like the Ministry of Health and Family Welfare, governs and guides the physicians all over the India and participate in any research activity which physicians intend to do, whether in the communicable or the non-communicable diseases. Sir has a vast experience in day-to-day clinical practice. His CV or the biodata is so long that if I start reading it, probably whole of the webinar will be just highlighting about his achievements. If I have to summarize about his efforts for hypertension, then it will be very precise that sir works for this particular disease. He has seen patients very closely with hypertension, hypertensive emergencies, and he knows where all we can fail in diagnosing hypertension, where all we can improve in recognizing patients of hypertension, and how can we together help in reducing the morbidity and the mortality caused by this devastating disease. So, Dr. Muruganathan, sir, I welcome you on this webinar from the Ministry of Health and Family Welfare. Sir, it's all yours. Thank you, sir.
Thank you very much for the nice introduction, Ramesh Agarwal, Dr. Pankaj, and all my good friends who have joined all from all over India. Good morning to you. Now, let me share the slides, and as I share the slides, I will also give a talk about, already Ramesh Agarwal had given the introduction about the World Hypertension Day. This year, the World Hypertension Day has got a theme: measure your blood pressure accurately, control it, live longer. Now, let me close this hide video panel. This I have to close. Okay, so correct blood pressure measurement is crucial and key for screening, diagnosis, management, and monitoring. The quality of blood pressure monitoring does not only depend on the possible limitations arising from technical aspects, but does more commonly also depend on the correct handling by the user. Guidelines on the correct methodology from various international professional bodies, but unfortunately it is not followed properly. The discovery of the blood pressure was more important than the discovery of the blood itself. Johns Muller, German anatomist, was saying. You see, adequate control of hypertension is the key for cardiovascular disease prevention. You know, the Christine Barnard, who did the heart transplant, he said once, I have saved the lives of 150 people by heart transplant. If I had focused on preventive medicine, like controlling blood pressure, I would have saved 150 million. So that is the importance of controlling blood pressure. You know, hypertension is the leading risk factor for preventable deaths. 10.7 million deaths per year. It kills more than any other condition and more than all infectious disease combined. For every 20 millimeter increase in systolic, doubles the vascular mortality. If you see, if the blood pressure is 115 by 75, if it increases by 20 millimeter of systolic and 10 millimeter of diastolic, the risk doubles. Then again, it 4 times and 8 times. So every 20 millimeter, the risk doubles. I know, unfortunately, the high blood pressure awareness, the treated and control is less. For example, less than 1 in 7 with hypertension worldwide have it under control. Biggest gaps are in diagnosis and control among those treated. Reaching 50% of the global control would prevent 1.7 million deaths per year. So average, only less than 14% are under control in the global area. There is a quadruple paradox in this. You see, it is very easy to diagnose, but often remains undetected. Very simple to treat, but often remains untreated. Despite the availability of potent drugs, often treatment with all is ineffective. And another paradox is, in spite of the incidence, morbidity and mortality is more than diabetes, only few hypertension specialists are there. There are a lot of diabetologists, nook and corner, but there is no hypertension specialist across the country. Then the hurdles to blood pressure control, diagnosis, screening not done, diagnosis not made, low attendance, inaccurate measurement. The treatment, there is no protocol, drug shortage, therapeutic inertia, and private sector and patient flow. Then continuity of care, no reminders, no recall system, medications not affordable, no information system, and low adherence. These are the challenges in diagnosis. That is lack of awareness at the population level, especially women and young, lack of proper knowledge to the set of the therapeutic goals, confusions are there, lack of opportunity screening, lack of education, health literacy is less, accurate BP measurement is not there, lack of facilities in healthcare system. There is no validated BP monitor and lack of home blood pressure monitoring, ABBM, to diagnose white coat hypertension, mass hypertension, nocturnal hypertension, BP variability, lack of technology skill, lack of research and registry, lack of hypertension specialists, then lack of private sector involvement. You know, one more interesting thing, whenever somebody comes to you for any problem, maybe little finger injury or fever, you should check the blood pressure of the person. All individuals above 18 years to be screened for higher blood pressure. Another data, we have an interesting data, longitudinal agency study in India among 45 years plus age group showed those identified as having hypertension, 22.6% have not been diagnosed despite they recently visited a health facility. This missed opportunity for diagnosis were more common at a private than the public health facilities. So, ladies and gentlemen, my message today now is anybody who comes to you for any problem, check the blood pressure. And I'll go one step further. Those who come as an attender, check their blood pressure also. So you get an opportunity for screening. And this is a very important slide. How do you measure accurately? I think every clinic should have this slide, and every paramedical healthcare worker should know how to measure the blood pressure correctly. No smoking, no caffeine, food 30 minutes before, quiet room, comfortable room temperature, 3 to 5 minutes rest, no talking, bladder should be empty, cuff small, usual or 3 cups you should have, arm bare, resting, and mid-arm at heart level, back supported, the feet floor flat, no cross legs, validated electronic BP upper cuff device. Take 3 measurements at 1 minute interval and use the average of the last 2. And this type of stool you should avoid, because in the clinic you have this type of stool, but you have to have a backrest supported. The pitfalls I told you can be patient-related factors, procedure-related factors, equipment-related factors, or you have to solution is standardized measurement technique. Use a standardized approach to BP measurement, and put it in the small simple way: right cuff size, right placement, right position, right preparation, and right performance. Remember the 5 R's. And the selection of the cup is very important. I told you should have three types of cups. That is small, middle, and large. The arm circumference, measure the arm circumference, and cup length should be inflatable part of the cup should cover 75 to 100% of the upper arm. And cup width should be 40 to 80% of the distance from the elbow to shoulder. And both obese patients need longer, wider cups, and small children need a small cup. And if you see, if you do a small cup, it will overestimate. If you use a large cup, underestimate. So you have to use correct cup size, correct cup placement, and you should not place the cup over clothing. And there is a new technology, a cup called Intelli Wrap Cup technology. This has got a very good patient-friendly, longer inflatable area with the cup, wraps all over around the arm. So you need not worry about where to place the cup. And these are the different sizes of cup available. The small is 12 into 22 centimeter, medium is 16 into 30, and the large is 16 into 36, and extra large is 16 to 42. So every clinic should have all the 3 different sizes of cup: small, medium, and large. So depending on the arm circumference, use the cup correctly. As I said, if you use a small cup, it will overestimate. If you use a large cup, it may underestimate the pressure. That's the importance of cup. Now, the key points I summarize. These very important points which you will have to remember. Place should be calm and quiet. Don't smoke, drink, or eat anything 30 minutes before the measurement. Bladder should be empty. Should sit comfortably for 5 minutes. Don't talk, especially mobile phones, both the doctors and the people who are taking the blood pressure. Speak or move. Don't cross legs. Back should be supported. Cup should fit properly, not too loose, not too tight. Cup placement should be correct. 2 to 3 centimeters above the elbow. The arm should be up to the level of the heart. Equipment should be calibrated. Inflate the cuff and record the BP. At the initial visit, take average of 3 readings taken at intervals of 2 to 3 minutes. For confirmation of diagnosis, record at least 3 sets of recordings on different occasions, and preferably you take confirm with the home blood pressure monitoring or ablative blood pressure monitoring. Measure the blood pressure in both arms at the first visit. use the higher of the two readings. In older patients at the age 60 above and diabetic patients on hypertensive therapy, the BP should be measured in both supine, sitting, and standing position to detect postural hypotension. And then these are the factors influencing the BP measurement. For example, if you take a caffeine or coffee, it can increase 10 millimeter. If you are urged to pass urine, 10 to 15 millimeter increase. Speaking, 7 to 10. If you are legs crossed, 2 to 8 millimeter. Smoking, 6 millimeter. Without back support, 6 to 10 millimeters increase. And if you put the cuff over the clothes, it is 5 to 50, varies. Smaller cuff, 10 millimeter more. Positioning of the bladder, you have to place the bladder at the heart level. If you increase level by each increases, maybe 2 to millimeter mercury. And then the meeting, 20 millimeters, working 16, walking 12. Then again, phone calls 9.5, TV watching 6.3, sleeping, of course, you will get less BP. So BP variations in various scenarios and situations. Now, these are the common 7 mistakes that the AHA says is unsupported back and then unsupported arm, wrapping the cuff over clothing, cups too small, sitting with crossed legs, talking, and full bladder. These are the 7 common mistakes one come across in the clinic. Now, this is the best practice for accurate BP measurement. Take the link and then you can always watch once again and tell your staff to get trained. Now, I have told you measure accurately. What is the next theme? Control. Then what is control? It is not just achieving a single target BP during one visit. You should achieve the clinic target BP, out of clinic target BP, 24 hours average target BP, nighttime target BP, and tighter. So this is called quantity of BP control. What is quality of BP control? You prevent morning surge and reducing BP variability. So once you say you have got BP control, these are all the things, both quantity and quality of BP control should be there and you should make sure it is there. And coming to the white coat hypertension, sometimes anxiety induced high BP in clinics. So you consider their home BP monitoring. And then masked hypertension, the BP is normal, but the BP at home is more. And how do you diagnose it? Suppose somebody comes to you every time in the clinic, you check the blood pressure. Blood pressure is normal in the clinic, but he has got target organ damage, HMOD, hypertension mediated organ damage, like in the form of fundus problems or microalbuminuria or LVH. You suspect masked hypertension. Check the blood pressure at home or with the ambulatory blood pressure or home blood pressure monitor. You should find out the white coat hypertension. Coming to home blood pressure monitoring, I am a very proponent and passionate about home blood pressure monitoring. I have so far given 15,000 home BP monitors to tribal areas and poor people. And I also request every one of you, you promote and popularize home blood pressure monitoring, which will help you to reduce white coat effect. It also provides multiple readings and improves patient engagement. You have to empower the patient. For example, if you give a weighing machine for a patient, an obese patient, they are engaged and empowered. Same way, teach them how to do a home BP, and that will help you to improve the control. And it also enhances the diagnosis of masked hypertension and white coat hypertension. And I also request you, whenever you give a gift to anybody for a birthday or a wedding anniversary or any function, you gift a good BP monitor, which will be useful for the patient, the person, as well as the family. It can be useful for mother, mother-in-law, father, father-in-law, the whole family, neighbors also. There you record the BP 1 hour after awakening, after urination, especially before breakfast and before going to bed in the evening. Record the BP at the time of recording. Record 2 consecutive measures at least 1 minute apart. Record BP 2 times a day, 1 in the morning and 1 in the night. Record BP at least 4 days, preferably 7 days. Now, these are the summary of the office blood pressure measurement. Measure after 5 minutes of rest, validated BP. Then also I said both arms and record heart rate to exclude the arrhythmias. And then to rule out orthostatic, you check the blood pressure in the standing, use a validated BP. Same way, these are the summary of the home BP monitor as I have already completed the points. Now, the inaccurate BP measurement can lead to misdiagnosis and ineffective treatment plans. In India, 98% of the automated BP devices sold in the market are not validated. So you see the website and find which are the validated BP monitors. Several online registries give the list of validated devices like Hypertension Canada, the British, Iris. societies tried BP, etc. And we also requested ICMR to publish the validated BP monitors. And then when you control the BP, even the millimeters matter. For example, I tell you, if you reduce 2 millimeter systolic blood pressure, we have analyzed more than 1 million adults and found out 2 millimeter reduction of the blood pressure can reduce 7% reduction of the ischemic heart disease and other vascular mortality and 10% reduction of stroke mortality. And then this is another interesting slide you must all understand. By lowering 4 millimeter of mercury, you can reduce 12.5 cardiovascular events. By lowering 1 millimeter of LDL cholesterol, you are reducing 8.2 cardiovascular. By lowering HbA1c by just 0.9, you reduce only 2.9. So compared to reduction of blood pressure, compared the control of diabetes, the prevention is much more than 3 times or 5 times more in controlling the blood pressure. That is why we need no more hypertensionologists. There is no term called hypertensionologist. I had been talking for the last 10 years to start a lot of hypertension clinics and hypertensionologists and hypertension specialists. I think all of you should practice hypertension, promote home blood pressure monitoring. For example, if you reduce the systolic of 10 millimeter and diastolic of 5, you can reduce the CHD by 22%, or you can reduce 41% of stroke by reducing 10 millimeter of systolic and 5 millimeter of diastolic. And there are a lot of challenges in the management because lack of education. Why? Because silent killer. People will say, I don't have any problem. Why should I take? And you should also insist lifelong treatment. Once somebody's got hypertension, tell them it should be lifelong. Socioeconomic challenges. These are the two important, challenges. One is lack of adherence. Patients do not take medicine. That is why the government now giving the medicines at home. And then for 1 month, continuous supply, 2 months continuous supply, and they go to the home and check the blood pressure. And the clinician inertia, from the doctor's point of view, you should avoid this inertia. Proper drug supply throughout, a lack of teamwork to provide comprehensive treatment, lack of proper insurance, not using combination therapy. Nowadays, every guideline says combination therapy, lack of system in place, and you should have simplified evidence-based protocols, and there should be a lack of follow-up. You should have follow-up. And I think now ASHA workers are doing excellent work. They are sending a WhatsApp message to bring the patient back. Explain to you. And, lifestyle changes. Every day we do a lot of work, but we don't understand what we should do as a controlling the health, diseases. Not only diabetes, not only obesity, cancer, everything, you can do prevention by doing good lifestyle. Get moving and then focus on nutrition. Take healthy diet. Don't take junk food. Fast food always takes faster to the grave. You cut the salt. You should have only 2 grams, less than 2 grams, or 1 teaspoon of salt. And then whenever you go and buy any food outside, see the food label. How much salt is there? How much fat is there? You should develop the habit of looking at the food label and take your medicines properly. Check your blood pressure. I told you, home blood pressure monitoring. And then lose weight. Obese people, especially the abdominal obesity. The adults, male should have 90 centimeter and the female should have 80 centimeter. Cut back alcohol. Don't smoke. And then de-stress. Very important. Every one of us don't sleep well. We have to sleep at least 6 to 8 hours. And then yoga, meditation, stress reduction is important. And then you have to give a well-designed combination pill. And I told you simplified protocols for improvement in the management of hypertension. And we have wrote an article. I was also one of the authors in the policy statement of the World Hypertension League, where we said simplified protocols will help you. And then I'll summarize what all you should do. Clinician execution flow chart for the management of hypertension. First, measure the blood pressure accurately. Then detect white coat or mass hypertension by using ABBM or HBBM. Evaluate for secondary hypertension. Identify target organ damage. Introduce lifestyle intervention. Identify and discuss treatment goals. Use ASVD's risk estimation to guide BP threshold for during drug therapy. Align treatment options with comorbidities. Account for age, race, ethnicity, sex, and special circumstances in antihypertensive treatment. Initiate antihypertensive pharmacology therapy. Combination therapy is the key now. Ensure appropriate follow-up. Use team-based care. Telehealth. Detect and reverse non-adherence. Detect weight coat effect or mass uncontrolled hypertension. use health information technology for remote monitoring and self-monitoring. You can remotely follow from your hospital itself. And this is the hypertension protocol introduced by the Indian Hypertension Control Initiative, where they have a very good protocol. It is followed by all over India. Many states are following. They give prescribe amlodipine, first lifestyle modification, and then amlodipine 5 milligram, Madhya Pradesh, and increased amlodipine 10 milligram, and then we start on 40. They increase to 80 milligram in the fourth visit. And if it is not controlled, they add 12.5 milligram chlorthalidone. This is Madhya Pradesh protocol, Indian Hypertension Control Initiative, which was started by the government of India, state government, WHO, ICMR, resolved to save lives. Whereas every state has got a slightly different protocol. In the Maharashtra protocol, they give amlodipine 5 milligram first time, then add telmisartan 40, increase telmisartan to 80, then increase amlodipine to 10, and then add chlorthalidone. So every state now doing this project, Indian Hypertension Control Initiative. And then there is now digital health has come in a big way. So absenteeism of digital health in hypertension management in India. So what is the digital health? Self-screening. Then a lot of smartphone apps, self-monitoring with automated BP cuffs. And then self-monitoring and management automated BP cuffs, telemonitoring and virtual clinics have come. So this is the usual care. Now digital medicine has also come. And I'll summarize, comparing the office BP, home BP, ambulatory BP in every patient, and use artificial intelligence, digital health in BP and the future trends. You should not overdiagnose or over-treatment, because unnecessary treatment also inaccurate because of the inaccurate BP readings, undiagnosed hypertension, missed diagnosis, and BP errors. If incorrect BP measurement affect risk assessment, and especially rural setting, there are a lot of challenges in rural healthcare, and economic impact of BP errors, costs and burdens of healthcare due to incorrect BP readings. So these are all the things you should do. And hypertension control still remains a largely unmet challenge for public health system in India. BP measurement techniques and anti-hypertensive drugs are not always optimally used in clinical practice. Identification of white coat hypertension, mass hypertension is possible through combined use of office BP and out of BP like home BP or ambulatory BP monitoring. Consistent BP control is important. Single pill combination is preferred. Home BP, telemonitoring, mobile health technologies may improve patients' adherence, compliance to antihypertensive treatment. And we are very proud, on 21st September 2022, the UNITEF Award at UN General Assembly was given to Indian Hypertension Control Initiative, where we, that time, 130 districts, 23rd states, 34 lakhs of people. Now, recent studies, we can say the more than 50 lakhs of people are under this scheme, and more than 50% of the control in hypertension. So that's a good news. It's a pilot study. We have to follow the same thing. So I'll complete. You control over the diet, takes regular exercise, has time to relax, does the right toil in discharge of duties, observes proper hours of sleep and awakening, balance in his actions and reactions, emotions and reasons, duties and rewards, conquers disease, says Bhagavad Gita. So this is still holds good. So I think we'll have to have a lifestyle modification. I know challenges are what makes life interesting, but overcoming them is what makes life meaningful. Thank you for your attention. I'll be very happy to answer any questions. Not all of us can do great things, but we can do small things with great love. Thank you very much. Over to the organizers.
Thank you very much. Yeah, thank you very much, sir. Thank you for that excellent and very comprehensive deliberation on hypertension. And from the beginning, you very rightly told that we all know, but we don't practice probably, that that doing 150 heart transplants is not good as comparing to 150 million people if we look for the hypertension and related diseases. So we can even save heart transplants or kidney diseases or things like which complicate after such basic problems. And the quadruple paradox which you had said, and you have rightly actually used the word hypertensiologist, which is not there in the literature, but that's very true. And you have been advocating this for the last so many years. And rather, this hypertensiologist, we wish to empower our very grassroots workers, which are working in the fields, to take the blood pressure and at least recognize the very asymptomatic population of our country, and at least escalate them to a higher center, or maybe give some basic medication which you have mentioned about amlodipine and telmisartan, which already are also a part of the government's program of giving them at the very basic Anganwadi workers even. And the techniques that which you have mentioned about how to measure it was very elaborative, and that is very educative for everyone, of even those working at the tertiary care centers, or those working at the very grassroots level. And as we celebrate the day, like the World Hypertension Day, and the best gift which we can offer to anyone is the blood pressure instrument. Probably we don't realize it today, but that is the thing which should be distributed by whosoever could afford it. Let me see, sir, if there is any question from the chat box. Uh, they have asked, the eco team have asked for the questions. Uh, right now, there doesn't seem to be many questions in the chat box, sir. Probably, yeah. One question they have asked is, sir, that how do comorbid conditions like diabetes or kidney diseases influence the choice of first line antihypertensives
Yeah.
medication in workers, sir? Yes, sir.
Yeah. See, in kidney disease, especially with proteinuria, the first line drugs can be ACE and ARB. Even diabetes, the first line drug will be ACE and ARB. Having said that, the target for the kidney disease and diabetes is less than 130 systolic and 80 if you can maintain it. And as I said, it should be combination therapy. So once you start with ACE or ARB, then you combine with calcium channel blocker as a single combination pill. They're available. So that will be the line of treatment. And depending on the control, we can add the third drug, chlorthalidone. In a kidney disease, you have to look for the parameters like serum potassium and then EGFR and creatinine. Depending on the EGFR, for example, if the EGFR is less than 30, then you can use loop diuretic. If there is more than 30, you can use chlorthalidone. And again, if the creatinine or potassium doubles, then you will have to be very careful using ACE inhibitor. Otherwise, ACE and ARB also is good for both kidney and diabetic problem. So only parameters is you check the lab tests, creatinine and the EGFR and potassium. And depending on that, you can use the drugs. And if the potassium is high, you cannot use spironolactone. So depending on these parameters, we can change the drugs and then control the blood pressure. But whatever said and done, you have to control the blood pressure, and the target and threshold is little less for diabetes and kidney disease.
Sir, very rightly said, sir. And there is another very pertinent question, sir. And probably this is your favorite topic, sir. Like fluctuating blood pressure. One fellow has asked that if the blood pressure fluctuates throughout the day, then how to monitor it, and what to do for this, sir?
Yeah, actually, the BP variability is a big problem. You see, there is a different variability, minute to minute variability, hours to hours variability, day to day variability. And depending on the variability, the best best instrument we can use is home BP monitor, especially. And somebody has got BP variability, they can easily get a home BP monitor and get the BP variability. The golden standard for BP variability detection is the ambulatory blood pressure monitoring, where you can have the circadian rhythm normally. You have a normal, there is a dip during night, and then there is a small surge in the morning. So this is circadian rhythm, which we can measure with the use of ambulatory blood pressure monitoring. I would suggest everybody who's got hypertensive, at least they should undergo once at least ambulatory blood pressure monitoring, which is the gold standard to find out nocturnal hypertension and morning surge. Because many people, they have the blood pressure under control during the daytime. We don't know what is their blood pressure status during night and morning surge. That's why if you do the ambulatory blood pressure monitoring and you can find out the circadian rhythm, there may be non-dippers. So in those people, you have to adjust the dose accordingly. You have to add one drug in the evening also, so that the blood pressure under control. Now the home blood pressure monitoring, the newer ones have come, which also helps you to find out the nocturnal hypertension. This this is a new BP monitor which records the BP at 2 a.m., 3 a.m. and 4 a.m. That is also good enough to find out nocturnal hypertension, BP variability. So BP variability, again, once you know the BP variability, the choice of drug is very important, because calcium channel blocker is the drug of choice for the BP variability, because certain drugs like ACE and ARB may not control the BP variability. And one of the things is atenolol was ruled out from the market because it increases the BP variability. It doesn't reduce BP variability. So that's how when you do the BP variability, the choice of the blood pressure drugs varies. And of course, nowadays, everybody now, as I told you, using calcium channel blocker amlodipine, which is good for BP variability.
Yes, very rightly said, sir. There are many questions in the chat, sir, but because of the paucity of time, every question cannot be taken at this platform. But yes, Eco team will tell the participants that how their queries will be addressed by our expert. Avdesh, can you guide the participants how their queries will be addressed?
Sure, sir, sure. I'm just sharing my screen and I'll be explaining to them and how it can be possible to share their questions with us, and sir can take it on later on, and also they can review the questions on the same platform. So just allow me a second. Yeah, so dear all participants, whenever you will visit on your program, then you will see such kind of view, the particular program you have already joined. For example, this is for Ministry of Health and Welfare. You have joined Ministry of Health and Family Welfare Eco NCD webinar. So a lot of buttons are available here in the discussion button. And we have two types of the announcement and conversation. So you must not having announcement button. You must have conversation. So here you can post your questions like this, and we will get the questions and we will share with the sir. And after that, it will be posted on announcement tab, and you will get the answers. Also, for any query, we will be posting continuously. You can also directly reply to their announcement and conversation. We will get to know, and also that can help you to understand the perspective according to your question criteria. So hope that will help. So
Yes,
Yeah,
definitely. Yeah,
I'm
definitely.
always available, Avdesh. You send the questions, I will answer.
sure,
No
sir.
issues at all.
Sure, sir. So the question, as soon as I'll get from the participants, we'll be sharing with you.
I'm very glad so many compliments have come. Wonderful session, excellent webinar. I'm thankful to all the participants who
Yes, sir.
really enjoyed my talk. My drive home message is please promote home blood pressure monitoring. Please focus on hypertension, because if you control hypertension, you can save many lives. The morbidity and mortality, the incidents are more than 3 times more than diabetes. So you please concentrate on hypertension. When somebody comes with diabetic hypertension, you can focus on diabetes treatment as well as hypertension, because controlling hypertension can save more lives. So unfortunately, because it's a silent killer, and there are not many people take this hypertension as a specialty, unlike the diabetes. So I request even the diabetic specialists to take this hypertension as a specialty and focus and control. And as I said, control is the key, and the accurate measurement, you have to train your staffs. And the world theme is measure accurately, control, live longer. And follow-up is also very important. And you always develop a simplified protocols so that easy handling and easy treatment.
Definitely, sir. That is a very word of wisdom from your mouth, and probably we all will follow this. And with this, we come to the end of this webinar, sir. And I must thank you and congratulate you for sparing your time and advising us on this important topic of hypertension. At the same time, I would like to thank Dr. Swasti Charan sir, who is the senior most person in this webinar series and who has initiated this whole process. Along with this, the whole NP-NCD team, I would like to thank particularly Dr. Pankaj, Dr. Vinash, who has been sincerely working to conduct these webinars. Very, very thank to all the participants who have joined and spared their time and listening, and probably they will be implementing what Dr. Muruganathan sir has said. Many thanks to Mr. Avdesh, who is consistently supporting the ministry with his technical team.
Thank
And
you, sir.
with this we come to end of this webinar. Thank you, Dr. Muruganathan sir.
Ramesh, everybody is
Yeah,
asking my PPT. I have already given
yes,
the
sir.
PPT to Avadesh
Yes.
and in the
PPT
group.
will be yes, sir.
Yeah,
PPT
you
will
can use the PPT what I have given to you.
yes, sir. PPT will again be shared by Mr. Avdesh on the platform, and the queries will also be given.
Sir,
Mr. Avdesh.
the PPT will be uploaded on our platform. So I would like to again inform all the participants. You are joining this platform through like webinar by a Zoom, but this is not about Zoom. This is about IACO. Actually, this IACO helps you to connect with the Zoom and having this webinar. So I request everyone to visit the IACO platform, and there you will be getting the PPT. Once again, sir, shall I show them, sir,
Yeah,
Ramesh sir?
yes, it
Okay.
will be good, please.
Okay, so once you visit on your IACO platform, so there is a participant view, and for whatever program you have been registered, you may get the batch system, and from there must be four tabs like schedule, content, report, and discussion. From discussion you can post your questions, and from the content tab you can upload, sorry, I'll be uploading, and you can download the PPT. Like this particular PPT is already available here. You can use the download button and it will be downloaded offline. As soon I will be uploading, so by afternoon, after 2 p.m., you can download this PPT, or you can also view it at online, like this type. So this will be helpful if you don't want to download it. Thank you so much.
Okay, so we are winding it, sir. Thank you, Dr. Mugnathan, sir. Thank you, Avdesh ji. Thank you.
Thank you, sir.
Hope Ramesh, you are happy about the all the presentations, everything, Ramesh?
Yes, sir, it was excellent. You can just see in the chat box that people are so happy, and probably they will be bothering you and will be taking much of your wisdom. They will be asking you many questions, sir. We can also share the email of Dr. Muruganathan, sir, and
Yeah, no issue.
probably, yes, sir, probably they will, it will be very nice to Mr. Avdesh.
Sir,
Yeah,
it
they can
will be
also
posted.
ask questions.
Yes, sir.
Yeah,
It will be posted, the email address in the conversation tab. They can access the email there.
okay.
Okay, thank you,
So
sir.
every
Thank you.
participant had to visit iaco.org, and they can access the PPT. Also, they can post their questions, and they can have the email address of Dr. Mugnathan sir.
I'm glad more than 1,000 people attended. I'm really happy, Ramesh, to see
Yes,
so
sir.
many people attended this. At least
Thank you,
if
sir.
10% of people who follow what I said will
Yes,
be
sir.
very, very useful, I think.
Yes, sir. That is the whole idea of this webinar, sir. People like
Yeah.
you come and advise, sir. So it will be like a chain reaction, sir. At least these 1,000 people will certainly spread the message to another many lakhs of people, sir. And they will implement this what you have said, sir. They are all our backbone.
Yeah, that's why I said, no, people spend a lot of money in transplant. Of course, they save one patient,
Yeah.
but the same amount if you do for controlling the blood pressure or preventive cardiology, you can save 150 million people. So that's how very important to, even the small things, you have to take with love and passion, like Mother Teresa said. So
Yes, sir.
good, Ramesh. Thank you so Ramesh. Thanks for the opportunity. Then we'll meet again.
Yeah. Thank you, sir. Thank you, everyone.
Any
Thank you.
other program also like this, please invite me. I will be happy to join.
Sure, sir.
I thank the Ministry of Health for giving me that opportunity. I thank Pankaj and the NCD people.
Thank you, sir. So shall we wind up, sir?
Yeah, we'll
Yes, sir.
wind up.
Please.
Thank you.
Thank you, sir.
Thank
Thank
you.
you so much, and thank you, everyone.